Hello, my name is Zahn Thompson, and today we are talking about increasing compliance with pain reassessments within 60 minutes of administering pain medication. My committee members are my chairperson, Sabrina Condon, my second reader, Elisa Struer, and my committee member, James States. The aim of this project was to increase the rate of compliance with pain reassessments within 60 minutes of pain medication administration. This posed the research question: does nurse awareness and visual aid reminders help increase the compliance with pain reassessments within 60 minutes of pain medication administration? A little background: uncontrolled pain is defined as pain that persists at a level that causes emotional distress, disrupts daily life, or prevents normal functioning. Studies show that only around 20% of patients state that their pain is controlled in the acute care setting. Currently, pain reassessments are only completed and documented between 32 and 75% of the time. This means that between 25 and 68% of patients are experiencing pain, may not have adequate pain management, and experience negative outcomes due to untreated pain. It is clear that there's a wide gap in the compliance of pain reassessments within 60 minutes of pain medication administration, and that there is a significant need to close the gap. Pain is unavoidable in most cases, but uncontrolled pain has the potential to lead to serious negative health outcomes that affect not only the patient, but the nurses and the healthcare facility as well. Uncontrolled pain can be detrimental to a patient's hospital stay. Uncontrolled acute or short-term pain leads to chronic or long-term pain in up to 61% of cases. Studies show that unmanaged or uncontrolled pain in the acute care setting leads to an increased risk of atelectasis, respiratory infection, myocardial infarction, cardiac failure, and thromboembolic disease. Another study shows that uncontrolled pain can lead to patients experiencing delayed wound healing, respiratory complications like atelectasis, immune suppression, depression and anxiety, and a higher risk of acute pain permanently transitioning into chronic pain. Those are only the physical complications. The emotional, psychological, and financial consequences of untreated pain can be equally devastating. On staff, the impact is increased burnout, increased workloads, and decreased staff satisfaction. Studies indicate that patients experiencing uncontrolled pain cause moral distress, emotional exhaustion, and compassion fatigue for nurses. The impact of untreated pain does not only apply to patients, but it also impacts healthcare facilities as well. Statistics show that in the United States, the costs of treating unmanaged pain are more than those of cancer and diabetes combined, estimating well over $100 billion per year. This cost comes from increased readmission rates due to uncontrolled pain, increased costs treating complications from pain, increased length of stays, and higher rate of opioid dependence contributing to the rising admission rates. These are only some of the few of the serious complications that can arise from untreated and uncontrolled pain in the acute care setting. Pain management is a popular topic among studies in today's age. With rising opioid epidemic, the need for adequate pain control is needed now more than ever. The gap in pain reassessment completion and documentation has been found to be a result of multiple attributions. Like I mentioned before, current pain reassessment rates are as low as 32% for all of the pain medication administrations in the acute care setting. Studies have also shown that low compliance rates with pain reassessments have been due to the forgetfulness of the medication administrating nurse or failure to document the reassessment in the electronic health record. High acuity and high workloads also significantly contribute to the failure and to complete and document reassessments within 60 minutes. When interviewing nurses, studies have found that nurses viewed pain assessments as a forgotten priority or deemed them unimportant. The time frame of 60 minutes for reassessment completion is also a key part of adequate pain control. Many studies have looked at the time for various medications to take effect. They have revealed that the average onset of intravenous pain medication is 5 to 10 minutes, while the average onset of oral pain medication is 30 to 45 minutes. Additionally, the peak effect for intravenous pain medication happens between 15 and 30 minutes, and for oral pain medication, it happens between 45 and 60 minutes. This data suggests that the most effective time to accurately evaluate pain medication effectiveness is 60 minutes after medication administration, ensuring that the pain medication has time to fully take effect before the pain is reassessed. Reassessing pain earlier than medication onset could mean that the patient are receiving too much pain medication and also increases the risk for patients developing respiratory failure, CNS depression, and opioid dependence. In one study conducted by Buffo-Twum, using a visual reminder for the administering nurse to complete the pain reassessment within 60 minutes of pain medication administration, compliance increased from 67% to 79%. It was also found that nurses reported increased satisfaction with the visual reminders and reported minimal disruptions to workflow. This DNP project regarding the need for consistent pain reassessments after pain medication administration is best represented by Marion Good's middle range theory on acute pain management. This model, often referred to as the balance model, goes into detail of the importance of balancing pharmacologic and non-pharmacologic pain management techniques with attentive pain management and active patient participation. This framework is split up into 3 propositions. The first proposition is the use of multimodal pain reduction techniques. This relies on using multiple techniques to reduce and manage pain rather than a single therapy. Combining both pharmacologic and non-pharmacologic therapy to reduce pain will minimize the need for opioids or other strong pain medications while also minimizing side effects of medications. The next proposition is attentive pain management. Good talks about severe and uncontrolled pain leading to delayed healing and recovery. The need to stay on top of pain control is imperative so that it does not get out of control, requiring a high level of pain medications to relieve it. Marion Good suggests that pain is assessed at least once per shift, but optimally every 4 hours, with accurate pain reassessments after the intervention. She also speaks on the importance of documenting all pain assessments and reassessments to ensure that the pain is controlled through a change of shift and transition of care. The third proposition is patient participation. Good believes that patient participation is crucial to managing their pain. Pain is subjective, which means that only the patient knows the details of their pain. Involving patients in their pain management plan will ensure that accurate prevention techniques are being used to treat patients' unique pain. Patients are also not the only person who can are the only person that can tell you that they are in pain or that the pain reduction techniques are used are adequate. This is important when assessing and reassessing pain so that appropriate interventions can be taken. Involving the patient in their pain management plan allows the patient to be present in their care, which improves patient satisfaction scores. Marion Good's middle range theory of acute pain management is the most appropriate to use in this DNP project because it provides an evidence-based framework that emphasizes the need for regular pain assessments and reassessments. The framework talks about how it is vital to assess pain at regular intervals and to reassess pain after interventions have been deployed. The goal of the Scholarly project is to increase compliance with pain reassessments after medication administration, so this framework makes it very clear to emphasize the need for regular pain assessments and reassessments. Using this framework in the project helped guide the student and educate the staff members involved in the project. This project was a quality improvement project that identified the root cause of a decreased compliance with pain reassessments following medication administration and implemented visual poster reminders as well as educational handouts and in-services to optimize workflows and deliver a meaningful result. IRB approval was obtained from Maryville University as well as written approval from the hospital prior to implementation. The project team was carefully selected and each person played a pivotal role in the project's success. The student met with the manager of the unit to identify the problem and to set a goal for the project. The manager also outlined the unit workflow and aided in how best to approach the implementation. The unit educator assisted the student in the educational in-services and educational handout that was placed in the huddle binder. She facilitated the in-service times and coordinated as many staff to be present as able. The student appointed 2 project champions. One project champion was a night shift charge nurse, and one project champion was a day shift charge nurse. This allowed the project to run smoothly during the times that the student could not be on site, and any questions and concerns that were raised could be relayed back to the student. The facility utilizes a numerical rating scale as well as face, legs, activity, cry, and consolability, or the FLAC scale, and the critical care pain observation tool, or CPOT. All 3 tools are essential in the intensive care unit because patients range from the ability to verbalize their pain to the inability to do so due to barriers such as intubation, sedation, critical illness, and more. Each scale has been proven effective for accurately evaluating a patient's pain in the intensive care unit. The NRS is a tool that is used to assess the severity of pain in real time using a 0 to 10 scale, with 0 meaning no pain and 10 meaning the worst pain a person can feel. This scale is most used throughout the hospital. In an intensive care unit, patients may not be able to use the NRS because it requires verbal or written communication that not all patients are able to accomplish. The FLAC and CPOT are especially important in patients who cannot communicate because they use body language and nonverbal signs of pain to treat unrecognized pain. The FLAC tool uses distressing behaviors such as crying, facial expression, body movements, and more to assess pain levels in nonverbal patients. The CPOT was developed specifically for intensive care patients. Much like the FLAC, the CPOT uses facial expressions, body movements, muscle tension, and compliance with the ventilator for critically ill patients. Each of these scales are simple, reliable, and valid tools to evaluate both verbal and nonverbal signs of pain for every patient. The data collection instrument utilized nominal values to qualify pain assessments abstracted from the EMR, converted to numbers to record outcomes. All pain assessments were reflected on the pre- and post-intervention collection data. Data collected for the purpose of this study was utilized information reflecting pain assessments related to the individual patients. The implementation period lasted 10 weeks from October 5th, 2025 through December 7th, 2025. There was a retrospective chart review for the pre-implementation data that was collected between July 7th, 2025 and October 4th, 2025. A data collection tool is currently used on the intensive care units to gather a report to outline the percentage of pain reassessments that are being completed. This tool was used to identify a problem in the rate of reassessments being completed. The unit's goal is to complete 100% of pain reassessments, and this scholarly project aims to bridge the gap to get the unit to a goal of 100%. The information gathered from the electronic health record was de-identified prior to being imported into the report. The system creating the report automatically de-identifies the data before the research results reach the manager or student. The report identified the number of patients receiving pain medication, as well as the number of nurses who completed pain reassessments following medication administration. The same reporting system was used pre- and post-intervention periods. The use of an anonymous suggestion box was placed at the nurses' station for nurses to leave feedback or make suggestions and was checked at the end of the week. Over the 10-week implementation period, there were 2 suggestions. One suggested applying more posters to areas that are high trafficked, like the bulletin board, staff bathrooms, and the break room. Another suggested placing posters in the patient's room so that the nurses and the patients could help make sure that the pain reassessments were being completed. Both suggestions were applied, and the changes were made during the implementation period. The setting of this study took place in an intensive care unit of an urban hospital located in a large metropolitan area in the Midwest. This ICU had 18 beds and on average cared for approximately 1,500 patients per year. This facility was a level 2 trauma center. This unit has experienced suboptimal pain reassessments within 60 minutes of pain medication administration and is working toward improving the compliance with nursing staff. The facility adopted the numerical rating scale, the critical care pain observation tool, and the face, legs, activity, cry, and consolability tool to assess and reassess pain using numerical values. The pre-implementation retrospective chart review revealed 14,064 pain medication administrations, and the post-implementation retrospective chart review revealed 13,728 pain medication administrations. This meant that each sample size was adequate at effectively evaluating the change. The data collected to evaluate the compliance with pain reassessments within 60 minutes of medication administration was analyzed using an upper tail z-test for the difference of 2 proportions with an effect size of 0.05. A 2-proportion z-test evaluates whether 2 independent populations significantly differ in a binary outcome. The upper tail z-test for the difference of 2 proportions was used to determine if there was statistically significance between the pre- and post-intervention compliance rates. The upper tail z-test for the difference of 2 proportions has a significant level of 0.05 and a confidence level of 95%. This means that if the project were to be conducted 100 times, the outcome would be the same 95 times. The achieved power of study is 1, indicating maximum certainty of detecting a true effect. With a lower confidence interval, this indicates that the results of are precise as opposed to a wide range, indicating that the results may be uncertain or there is a small sample size. This project proved to be statistically significant at increasing the compliance rates with pain reassessments within 60 minutes of pain medication administration. During the 10-week pre-implementation phase, the compliance rate for pain was 73.5%, with 10,944 of the 14,064 pain medication administration documentation, including a pain reassessment within 60 minutes of administration. The post-implementation phase had a compliance rate of 77.8%, with 10,097 of the 13,728 pain medication administrations documenting a pain reassessment. You can see the two figures to the left. The statistical analysis revealed that there was a significant statistical significance with the p-value less than 0.0001. Themes identified throughout the project were poorly informed nurses on the importance of effective pain management, the limited knowledge of the adverse effects of uncontrolled or unmanaged pain, and the unintentional oversight due to busy workflows for the nurses. The suggestion box proved to be helpful for nurses having a voice during the project, which revealed to be something the nurses feel that they are lacking when it comes to change. Providing education opportunities for improvement during the project provided an opportunity for nurses to understand the significance of the change and allow their voices to be heard. When speaking to several nurses after the implementation phase, it became clear that providing a sound rationale and evidence to support the change allowed nurses to better grasp the importance and feel motivated to make the change. They stated oftentimes changes are made and nurses are instructed to change their workflow with little to no information or understanding the why behind the problem, and that prevented nurses from accepting the change. There were a few limitations for this project. The biggest limitation was the indication of medications being administered. One of the most frequently used medication for pain is Tylenol. Tylenol can be used for both pain and to treat high fevers, and Tylenol that is used to treat high fevers does not need a follow-up pain reassessment, as the effectiveness is measured by the patient's temperature instead of a pain rating. Similarly, medications like fentanyl, ketamine, morphine, and more can be used as a sedative to a patient that is on a mechanical ventilator instead of for pain. The data collection system did not differentiate between Tylenol that was used to treat pain and Tylenol that was used to treat fevers. Another limitation was patients who are unable to report their pain. Pain is subjective, meaning that it cannot be quantified by numerical data and can differ for each patient. Conducting a pain assessment and reassessment on a patient who cannot communicate pain is difficult and can lead to inaccurate assessments and subpar pain control. Furthermore, a patient who is receiving a paralytic is not able to report pain and may not give off nonverbal cues that fit the 3 pain scales used by the unit. This leads to inability for the nurses to assess pain while still administering pain medication, resulting in quote-unquote missed pain reassessments. Not all staff were accepting of the change, and a few were unwilling or unhappy about changing their current workflows. No matter how much education and awareness brought before a change, there will always be nurses who push back against adopting different workflows. Finally, nurses reported pain-seeking behaviors as a potential barrier. Patients who are seeking medications will give inaccurate or over-exaggerated pain ratings in an attempt to receive extra or higher strength pain medication. Patients exhibiting this behavior make it difficult to remain dedicated to pain reassessments and continue to offer pain management techniques. It is important to remember that pain is subjective and a patient's behaviors are not always 100% indicator of how much pain they are in. The success of this project is something that can have a major impact on the way that pain is managed in healthcare. Change is difficult in all aspects of healthcare, and resistance to change is inevitable. However, there are methods to decrease resistance and facilitate a smooth transitions in the future. Going forward, it is recommended that these interventions be placed in all acute care facilities to improve compliance with pain reassessments. Additionally, educational modules should be created and sent out to all bedside nurses, patient care technicians, and unit leaders to inform and educate staff on the importance of pain reassessments. Bringing awareness to this topic proved to be extremely beneficial for nurses to incorporate and keep them motivated when implementing the change. Patients should be involved in the education and pain management regimens should be discussed at admission, discharge, and transfer to a different unit, and at each change of shift to facilitate closed-loop communication. Posters can be added to patients' rooms where they are visible to the patient in an effort to remind the patient that if their pain is not controlled within 60 minutes of pain medication administration, additional interventions may need to be requested. To sustain improvements, quarterly education should be handed out to either paper or electronically to account for the fluctuation of staff members to include new hires. Unit leaders should conduct audits on compliance rates and implement additional education if compliance rates start to decline in efforts to re-educate and remind nurses of the significance of the increased compliance. Reward-based programs can be implemented in the short term to help facilitate the change and keep nurses motivated. Once the change has been adopted and nurses adjust to the change in workflow, less oversight will be needed unless there is a decline in competence. Future research is needed to evaluate the cost effect of increased compliance as well. Nursing as a practice is constantly evolving and adapting to include the best evidence-based patient-centered care. Nurses are the cornerstone of healthcare, and institutions rely on nurses to help facilitate changes made to healthcare. Implementing the interventions from this project's success will require the teamwork and coordination of care between nurses, patient care techs, patients, and unit leaders. Through a teamwork-based approach, patients, patient care technicians, and more will be involved in closed-loop communication and fill in any gaps that may result from the nurses forgetting to complete reassessments. This enhances the relationship between staff and patients, ensuring that everyone is on the same page and working together to provide the best care. It also allows patients to be more active in their care and feel like they have more control in situations where they don't have a lot of control. Since this is a nurse-led change, nurses are directly impacted by the intervention set in place. By educating the nurses on the importance of this change, they are better informed and better equipped to provide the most holistic patient-centered care. Through these interventions, there is a potential for patients to experience less pain, increased wound healing, and overall better outcomes. Improved pain control allows patients to have earlier mobilization and less complications, which can increase quantity and quality of life. As for nurses, reassessments following pain medication administrations provide a better rapport with patients, decrease nurse burnout and emotional stress, and decrease empathy fatigue. This leads to better work environments, easier workloads, and improved mental health. It is also improves communication and helps break down the barrier of intimidation that patients feel when speaking up for their health and wellness. Nurses are patient advocates, and increased compliance with pain control is a way to advocate to ensure that patients receive the quality care that they deserve. In conclusion, there is a significant gap in the compliance rates for pain reassessments within 60 minutes of pain medication administration. This gap leads to uncontrolled pain that can negatively affect health outcomes for all aspects of healthcare. The research has identified the cause of the gap being forgetfulness or pessimistic attitudes attributed towards pain reassessments. Educating nurses on the importance of pain reassessments and the detrimental effects on uncontrolled pain, as well as visual reminders for nurses to complete their pain reassessments, are impactful in closing the gap in pain reassessment compliance. Nurses need to feel more involved and motivated to adapt the change if they are informed on why the change is taking place and feel like they have a voice in the change. Limitations such as multi-use medications and inability to verbally communicate pain are barriers to completing pain reassessments within 60 minutes. And further research is needed on the financial impact of closing the gap in compliance. This is just one step to better pain management in the acute care setting and needs to be further studied to provide meaningful change. Thank you.